volunteered to stay back and take questions. So please ask questions. Let's have those questions addressed. We will do 15 minutes of this. I want to take the first set of, let's say, 3 questions from across the room. These questions are related to NHIF. If you have a question on contracting, payment, if you have a question on how contracting is going to happen under SHA, you have a question on how payments are going to happen, you have a question on how the primary healthcare fund will operate, any of those questions, this is the time. So can I get the first set of 3 questions? First set of 3 questions? Go ahead, Dr. Are you asking one question or are you asking the whole set of 3?
Fee for service or as per disease clusters. So which model are we going to take on for payment and reimbursement? On the second one is about subcontracting of claim management. I think Dr. Luen, Chair of SHA, has actually clarified on the aspect of the claim management shall be outsourced, which you said is not mandatory. Does it mean that we are looking at a scenario whereby SHA will first do the claims management and only if they are not able to do it efficiently, take it out to now consider outsourcing, or you are going to outsource it outrightly because you said SHA is not mandatory? On the third question is about the scenario whereby now we already have zoning of regions and we have different claim managing institutions. As service providers, do we have an outlet whereby we are able to rate these service providers? Are we able to rank them so that if a region is doing badly, do we have a way we can appeal to SHA so that a new team is brought on board? And then the last one is about contracting. You said KMPDC will be doing the contracting. Does it mean any facility that is licensed to offer medical services will automatically qualify to be enlisted under SHA? Because that is the same body. Thank you.
Okay, we take one more.
Thank you. I'm Godfrey Omondi. Maybe this goes to the chair. When you talk of claim settlement, the framework has not come out clear, especially on the rejection bit. We are talking of history of NHF, which is now currently transiting to the SHA. So what is the time frame of these rejections that might occur maybe during the claim management? And on the clinical audit, what are the timeline on these rejections? Thank you.
All right, so first questions, they asked for 3 people, but number 1, which provider payment mechanism are we going for? Are we going for capitation? Are we going for FFS? Are we going for diagnosis related groups? I don't know who wants to take that one. Chairman, you want to take that, or Jacinta, you want to? Sorry?
I can attempt that. So the Act requires SHA to publish, to prepare and to develop and publish tariffs
Are you happy?
And based on those tariffs, within the 9 days, then the provider will launch a claim. And the wisdom behind that is that we are all going to be digital, both the providers and SHA, and there will be no batching that is currently happening. So if a patient comes in and steps out, then we should be able to bill or raise a claim for that service.
So maybe just to clarify, for Dr. Odhiambo, are we still going to have, do you know whether we are still going to have capitation or not?
And just to add on to what Director Jacinta has said, the payment models we are going to adopt could be any of those three. You must remember that the Social Health Authority now has got 3 different funds with different sources of funding. So it might very well be that for the primary healthcare fund, we might have a capitation model. It might be the social health insurance fund, we have something else. For the emergency fund, we have fee for service. These are decisions which are still going to be made because our financial projections have not been firmed up and finalized. But at the end of the day, regardless of which payment model it's going to be, it'll be clear in your contract which model you have for which fund. So it's up to you to decide where you play. And the emphasis is on, we want to minimize human interaction as much as possible when it comes to the claims process. And that's why, coming to the issue of claims management, which has been asked also, and outsourcing, if we are heavily IT dependent, we intend that most of the claims process becomes automated. So there's minimal human intervention. And that's why the ones that need human intervention, the ones that are flagged by the system using the AI dashboard, for example, if the some that are flagged, we want to assume they're going to be a small percentage. So it's not like in the past where we're saying we're kind of verifying everything. So it's going to be a small percentage, and the question for us is that small percentage, does it justify having all our officers spread countrywide pursuing those? And that's why I said earlier, it might very well be that let us use local resources, for example, from other claims management providers who are already on the ground. So outsource those to them, and so when one is flagged, we say, please go and check out this one for us in Migori. They already have people there, as opposed to us having staff running around, looking around for a very small percentage of the claims. That's the reasoning behind the aspect of talking about outsourcing. And it must be clear, this outsourcing, people worry about it, thinking that we're going to be giving money to these claims providers to pay. Theirs is to verify and confirm to the Social Health Authority that you can go ahead and pay, or that this one has got issues, do not pay. So they are not holding funds. So some of the anxiety that has been there is that we are giving funds to somebody else to manage the process and make payments. It is, they are going to verify on behalf of the Social Health Authority. It comes back to the Claims Management Office and we pay. So we are still the ones who are going to be able to in charge of the process. The issue of zoning was purely because we wanted to balance the workload. You know, for example, you might find that 70% of the workload is in Nairobi. If you were to say that we have a tender and say people want to bid for these things, people will say, I want Nairobi, and nobody might want to cover Mandera or Garissa or Migori. So the issue of trying to balance out the workload to make it relatively even, that was the issue. But secondly, is to minimize the risk so that if there's one person who is not performing, it's not jeopardizing the entire system. The other aspect you asked about is contracting. I want this to be clear. Contracting is not a role for KMPDC. There's accreditation, which is done by those bodies. There's empaneling, which is automatic as long as you're qualified. So it's like playing golf. You've paid your greens fees, you've got the right to play. Then from there, contracting is dependent on if we can reach an agreement in terms of the services you offer and the rates and so on, and the contractual agreement. So that is where Social Health Authority comes in terms of the contracting. But empaneling is automatic. We're not going to be saying like NHIF was before, that we're going around doing inspections and saying you're at this level and we're going to accredit you, because that is part of the reason why there was a lot of issues to do with corruption in the past, isn't it? And that's what we want to move away from. So that is for the different bodies, and that's why I talked about earlier about the segregation and unbundling of the functions that were previously done by NHIF. And then I don't know whether that covers, I think that covers most of the questions that were asked.
Yeah, there was a question from Radiant about time frame for rejection of claims, whether that one has been standardized. Is it there? I don't know. The good
thing with most of these things, I do remember, if I remember well, I don't know the exact number. Make a mistake of paying it. We will chase you for it until we get back that money. That is the new approach. So people have got to realize it's not going to be business as usual. We are going to ensure that all claims try as much as possible. But you see, in the past, what has happened is there's been no enforcement. Right now, it is specified in the Act. The penalties are clear. And if there's anything to do with fraudulent activity, you're not going to get paid.
Thank you so much, Chair. We are taking another round of questions around NHIF and SHA. Any questions? Yes.
My name is Anne, Nairobi Radiotherapy and Cancer Center. NHIF owes facilities money, and you are taking over a new body. So in case they don't clear our pending bills, are you going to inherit the historical injustices, and how do you go about it?
Historical injustices, maybe we take a couple more. Okay.
No, that one I think is substantive enough for me to address because on its own. Now, from the moment the new act was signed into law and thereafter the appointed date of 22nd of November, all assets, all liabilities, all obligations of NHIF became those of the Social Health Authority. So number one, if what you're talking about is a liability, and it is, it has already been inherited by us. So there's no concern about it. The only key thing here is to ensure that we're in agreement on that figure. And that's why we're going to be launching a nationwide reconciliation exercise. You must remember there's the NHIF, which still has a board, which is in place, and is technically in place until end of November, 22nd of November this year. Then we have got the Social Health Authority. We have a transition committee, which is the one that's supposed to help us shake hands. So they're the ones directly interacting with the issue of verification of these assets and liabilities and claims and so on from NHIF. So it is important that we verify what those figures are, come to an agreement. My objective, and if it was up to me, is that we would settle all these bills before 1st of July. So that as we go to the new contracting cycle, we are starting on a new slate. That is my hope. And that's why I've said in terms of the issues to do with payments, it is getting the attention of the highest office in the land. And that is not, so there have been instructions even to the PS Treasury now to ensure that the government agencies that owe NHIF money release those funds. All right? So that's why I'm optimistic that this is going to happen. Much as I can't give you a time frame because it's not within my control, but I know HE himself has given directions to that effect. So the funds are going to be released, and for us, we have given a commitment as a Social Health Authority. The day the funds land in our account, any money that comes in is disbursed the next day. All right? So it's not like we're going to wait and say we're waiting for end of the month. For us, it is urgent because providers are key for us in terms of being able to deliver our mandate. So all those bills are going to be paid, but we have to be agreed. The transition committee's term is 6 months, and that has been running for a while. Please ensure you're in agreement on those figures, because for every provider, unfortunately, there's always a mismatch between what NHIF says it owed and what the provider says is owed. So that agreement needs to reach, because the tragedy here will be if they give us a figure as the transition committee, we're not going to be able to vary it. Because again, now that will be an audit query on our part, because you can't say, the transition committee cannot say we owe you 17 million and we pay you 34. It's not going to happen. We will pay exactly what we are told that has been verified. So what I'd emphasize is that an association, let us engage actively. We're going to be releasing a schedule for this reconciliation process that's countrywide to be very clear as to when we're in your region, so that this reconciliation is done and figures are agreed upon. So that for our Social Health Authority, we know how much is owed and how much we need to pay. I hope that addresses that question sufficiently.
I want us to be proactive enough. As early as yesterday, reach out to your branches and already start working on this. Don't wait until the last, we get to the attainment. Because I know we have some old claims from 2017, 2018, 2019. So please be proactive, and when there are challenges, reach out to your association so that they can make sure they facilitate for the branch to cooperate. wait, because if we have to wait, then there's going to be pressure, and my philosophy has always been
Visibility was removed, but I can assure you all claims, whether they're e-claims, whether they're whatever, regardless of age, as long as they are valid claims, payable, they will be paid and they'll form part of that final number that is owed to you as a facility.
Thank you. I'm Ivan Sodhiambo, Elder Maravin Nursing Home Baringo. So my question is in regard to contractual obligations. In the past, there have been a very clear contract that stipulates the procedures and even the guidelines in which things need and ought to be done. One of the challenges that the service provider has been facing is that NHIF is not honoring what has been agreed in the past in terms of the rates, when, especially for the surgical procedures. You do a procedure, you pre-auth as you had agreed, but whatever is going to be approved is way less. Two is honoring of the terms of the agreement. Right now, we are expecting the TOT is going to be reduced by the new scheme coming into effect, but how sure are we that even in terms of payment, if the contract says that the service providers are going to be paid within 1 week, within 2 months, then that's going to be so. Because right now, when you look at the current contract, it stipulated the time NHIF is supposed to pay the service providers. But you see, people are still talking about the debts of 3 years down the line, 4 years down the line, and reconciliation again is still taking place. So how sure are we that we are now going to be paid on time and things are going to run smoothly? Thank you.
Yeah, thank you. May I ask some questions? Dr. Wafula, Kisumu Heart Center. In this new arrangement, there's a focus on chronic and critical care. There's a specific fund to be able to deal with that range of services and people. Could you shed some light how it's going to work? Because the burden is rising. Most of our facilities are maybe level 2, level 3, and quite a number of those people may require level 4 facilities. Do we have enough level 4 facilities? There are also a number of level 3 facilities that are mainly focused on that range of services, including ourselves. So we don't deal with a lot of other cases. You've heard of the eye hospital, the radiotherapy center, the heart center, that range of services. How is it going to work when you have a level 4 that doesn't provide that, and yet you have a lower facility ranked lower that is providing that kind of service? What kind of referral system is going to work, and the funding mechanism? Critical care, if you think about NCDs and you think about severe illness, then you have to think about critical care. The number of ICU beds, HDU beds in this country is very low, extremely low. And yet, the people who need those services are many. What is this, how is this facility fund going to work to be able to improve those kind of services? Thank you.
Right, so we'll take one, and then we need to close that session.
Thank you, Chair. My name is Anthony from Granton, that is in Embu. I have one question, matters the 3 funds. The first one is the primary health care providers. Under this one, I have a concern matters the funding. Because you are talking of they will be receiving money from the exchequer. We have experienced in the past that you find a scheme like Enduafia, Rinda Mama, whereby we are waiting even for more than a year for us to get reimbursement of the same service that you have rendered. How are we going to manage it in the new scheme? Thank you.
Right, one final one there.
I'm Wegesa Emmanuel from New Busia Maternity and Nursing Home. First, I would like to appreciate you for your presentation. And indeed, it was sufficient to cover everything to what I thought. However, I also have a concern, and that is in regards to the contributions being mandatory. So my concern is, when it becomes mandatory, does it become a tax or is it still a contribution? And also, to follow up, you mentioned something about Article 43. And Article 43 provides for, among the rights we have health, we also have housing, we have food, we have water. And now we are setting a precedent whereby the attainment of these rights is being in a manner which undermines free will of individuals, in a manner that how housing came as a contribution, it ended up as a tax. Health has come up was initially a contribution, now it is mandatory. My fear is what is going to happen. I hope you have the answer. Are you going to force us on the food we are going to eat next?
Okay.
So, Mr. Chair, I hope you actually have something to calm my fears down.
All right, thank you for that. Dr. Lenyi, how do you want us to take these questions? We have a question on Linda Mama and Edo Afia timelines. We have questions from Dr. Nalo here on the level 3 facilities, level 2 facilities that are offering specialist services. You know, there are eye clinics, eye hospitals, categorized as level 3. You have radiotherapy centers, you have cancer centers, all right? And then, of course, we have the question of rights being encroached over there. I don't know if I'm missing another question.
Okay, my name is Julia from CTI Hospital. My question is on the benefit package, especially for ophthalmology, how that will be determined. We note that the current NHIF contract omitted some blinding conditions, and patients have been struggling to pay that out of pocket. So that is my concern. What is the scope of that benefit? When will it be determined? And where do we fall? Are we primary? Where do the specialized units fall? Thank you.
Thank you so much, CTI. So the other question which I don't want us to forget was a question from Eldama Ravin about timelines for payments. Is it any different now? We have a section in the regulations that says government does not pay interest. You know, in other words, if you delay beyond the stipulated time, facilities have nowhere to go. Is it going to be any different under the Social Health Authority? Because in our case, when we borrow money to plug the deficit that has come from delays, the banks charge us interest, whether it is on overdrafts or anything. But how is it going to be under SHA? Now we have also e-teams. They are running behind us. All these issues. Now, you can imagine with e-teams, the way they are structuring it, once we declare that, you know, the transaction, for them it is income, and it may never come. So just bundled up that with the question from Eldama Ravin, Chairman. Now, who do you want from your team to take?
Okay, thank you. I think our brother from Lucia had concerns about the mandatory nature of the contributions without delving so much into the whether it's justified or not. But maybe it's just important for us to understand that for a social health insurance scheme to function well, it has some key principles. It is grounded on some key principles, and one of them is that they are made mandatory nature, so that all of us carry our weight, as Chair put it earlier. You know, this is a social health insurance scheme, and all of us, including the government, play a role. So So the difference with the Social Health Insurance Act is that it has now, unlike NHIF, where the government's role was purely playing a role as a contributor in terms of supporting those who are not able to pay, but with respect to the Social Health Insurance Act, the government now plays a more direct role in terms of paying for those who are not able to pay. So the law obligates government to pay for you that has been assessed not to be able to contribute. So one of the principles of social health insurance, the world over, the way it's designed, is that it's made mandatory so that the scheme is sustainable and is able to mobilize enough resources for the scheme to be able to offer the benefits that are promised under the cover. So the way I want you to look at it is that it's not exactly a tax. This is not a tax. It is a contribution with the intention of you drawing benefits from this cover. So thank you very much. And that is how it's designed the one.
Thank you, Chair. Allow me to respond to the issue of Linda Mama, that is the government-free maternity cover. And as you are aware, the scope of cover is from prenatal, the actual delivery, and the postnatal care. Of particular note, I want you to take note of this, that Linda Mama is not an insurance. It is a revolving fund that NHIF administers on behalf of the national government. The way it works is that NHIF receives claims from healthcare providers, including Rupha. Once we receive claims, we do collate of the number of claims submitted and request reimbursement from the national government. I know, indeed, there's been a delay in reimbursement of Linda Mama monies, but I read recently, and the ministry has promised, among the funds they'll be releasing very soon will be Linda Mama payments. So it's my humble request and the prayer to be patient. We will be able to reimburse you immediately the funds in the NHIF account. And thank you for your patience.
Thank you. In terms of, thanks for the other panelists for answering the questions they have taken. Now, there's a concern about keeping contractual obligations and about approvals in terms of authorization and the manner that it has been done in the past and the terms of these agreements. Now, one of the things that we want to change as an approach is that I know a lot of the requests were there to, first of all, put terms of agreement and so on and durations inside the regulations. Personally, I don't think it was absolutely necessary. It is something that we would have liked to do, but I think that can be covered when it comes to the specific contracts, and that we've not gotten to that bridge yet. In terms of durations of payment, I have to be honest. These funds come from different sources. For example, the funds coming to the Social Health Insurance Fund, which is the contributors fund, are more within our control. So I'd be more comfortable saying that we can pay you within a specific number of days. For the Emergency, Chronic and Critical Illness Fund and for the Primary Care Fund, those funds come from the Exchequer. And so we're dependent on them. I would be very reluctant to put a timeline on that, and yet I don't have control as to when those payments come through. So it might very well be that those time constraints vary for the different programs. But at least for the ones from the Social Health Insurance Fund, I think we can be able to reach an agreement in terms of payment duration once we are clear how long the claims process takes. And the sooner that we can be able to pay, the better. I would want us to pay sooner rather than later. In terms of the Emergency, Chronic and Critical Illness Fund, I have to make it clear that the way the system is structured is that it is based on levels. First of all, you have to understand, because of the constitutional imperative that the government is meeting, the government provides funds for the Primary Care Fund from the Exchequer. That one, for you, any citizen to benefit from, all you need to do is register. Not fully paid up, just register. So start at level 2 and 3. Now, for you to be referred upwards to level 4, 5, and 6, now you have to be a paid up member. So if you are not paid up, your journey stops there. That has to be clear. 4, 5, and 6 is for those who are paid up members. So it's a contributors fund. So only the people who will be able to access that are people who are paid up members. Now, emergency services, again, are free for everybody as long as you're registered, and we have gone out of our way in terms of the Act and the regulations. This one, you don't even have to be a contracted healthcare provider for us to pay for those services. Anybody who is duly licensed, and if somebody lands at your doorstep and care is provided, as long as you're licensed to provide that care, the Social Health Authority will pay for it. So that's the only time when we go outside and make payments for people who are not even contracted. But the emergency fund is for everybody and is for free for the first 24 hours. Beyond that, the critical illness, chronic and critical illness fund, again, is for paid up members. So you cannot say you are not paid up and then you want to access chronic and critical illness funds. Now, there has been an emphasis in the past on this issue of levels. Much as the levels are still there and defined in terms of the referral system, my personal approach, and that's the approach we're going to adopt, is that we want people to access services. It is not necessarily dependent on levels. Before, there have been disparities, because you might find you're offering level 4, 5, 6 type services, and you're classified as level 2, 3. So there are going to be exceptions to these rules, and you must remember that we have primary care networks which are set up in such a way that we have level 2, 3s, and they refer to a level 4 as a hub. And that level 4 can be any, from a provider who is faith-based, can be a provider who is private or government. We don't really care. Us, what we want is that you're able to provide the service that you say you're able to provide. Now, of course, at the beginning, and I keep saying one of the biggest risks we have as a social health authority is we don't have control over the quality of services providers offer. And yet we need you to be able to deliver on our mandate. So initially there are going to be challenges. There are certain areas that are underserved. All right? You might find that somebody, we tell them to go to level 2, 3, and they say the nearest level 2, 3 is 30 kilometers away from me, but there's a level 4 right next door. So there's room for us to make exceptions. And that's why we said, even in the regulations, or a designated level 4 facility. We have created room for that. However, you must understand from our perspective, if you go and access primary care services at a level 4 facility, we are paying from the wrong pocket. We are paying from the Social Health Insurance Fund as opposed to paying from the primary care fund. So at the beginning, we'll accommodate that, but we are hoping the private sector, the public sector, the faith-based sector are going to step up the quality of services they offer so that now we can tell Wananchi, go to the level 2 and 3, you will get your services there. So at the beginning, there's going to be room for exceptions. So at the end of the day, even in terms of the critical care, there's going to be exceptions because based on the mapping, we've got a geo-mapping that is going on for those primary care networks. So we are setting up, we want to see which facilities and which region. And even at the time of registration, people are going to be choosing which primary care network they belong to. And that is going to be based on your residential area. Now, you know, in Kenya, we've got a home, and then we have home. Here I'm talking about the home. So I don't want somebody registering in my village in Siaya and saying that's the primary care network and you live in Nairobi, because that doesn't make sense. We want the place, the locality where people ordinarily will find you, and especially for people who are going to be visited by the CHPs, they need to visit and find you there. Otherwise they'll be looking for me in Siaya and I'm in Nairobi, isn't it? So that's the kind of approach that we're going to adopt, but to understand, to reassure the members of this association, we are not rigid in terms of this approach. There is flexibility, and in the past I've always emphasized, I want it to be that people can get the services as opposed to insisting on this issue of levels that sometimes doesn't make sense, because we want our members to be able to access care. Now, talking about mandatory contributions, this gentleman here is trying to drag us into a mtaro about housing and so on. That one I will not go into. But one thing that we can say, in terms of the mandatory nature of the contributions, it's an obligation. Let's be honest. At the moment, the system we have is not right. In fact, those who are in salaried employment are the ones who are carrying the weight for everybody else. You can be somebody who is selling mitumba and moves 300,000 shillings every day, and that person, all they need to do is pay 500 bob. So in terms of that structure, without the informal sector being made to carry their weight, this scheme cannot work. And that's where the means testing issue came in. The means testing is we just want to be able to determine, based on your household consumption and other characteristics, we want to tell what your level of earning is and therefore how much you should pay as a premium. But we can't have everybody paying 300 shillings. We'll even be worse off than we were with the 500. The benefits package has been expanded, and these discussions are still going to happen. So in terms of the contracting, in terms of the benefits package, in terms of the tariffs, we've not gotten there. And we're definitely going to call you and we'll have discussions. We might agree on some things, we might not agree on others. I want to believe it, if we disagree, we'll disagree and give you good reasons why we disagree, isn't it? Because you must remember the utilitarian principle, we want to get the best benefit for the most people. So it might very well be you say, oh, IVF is not covered. We'll say IVF, first of all, is too expensive. It's going to drain too much in terms of our resources compared to what we would be able to provide for other people. So there are certain services that might not be covered. We might not be able to compensate beyond certain rates for certain things, but that discussion we will need to have and we will reach an agreement. So providers will be actively engaged in this entire process, and that's the approach we are going to adopt going forward. Thank you.
All right, thank you, Chair. I think that has been very exhaustive. Somebody said you are a great communicator. You are actually doing a great job. Is there some question that's being locked out? Anywhere? Yeah?
Hello? Oh, great. First of all, thank you so much for all of making time to be here today. I think it's really great to engage so directly with all of us. There's been so much discussion already about SHIF, but I actually want to talk a little bit about PCNs, which we started to address a little bit in the last set of questions. I know that CHPs are already working, and I think that they're already doing a lot of work in the communities. I'm wondering, what's the timeline for setting up PCNs? It seems like by July 1st, we really need those up and running, and the time is running away from us. So I'm just wondering, sort of, what does that process look like? How do we participate? This is particularly important to me as the CEO at PENDA. We have 16 facilities here in Nairobi, and so we're just trying to figure out, like, how do we support the government as we put in these PCNs? And then just as a related question for us, I think many of us here have taken a very forward-looking approach to the digitalization of healthcare, and I understand that as part of SHIF, there's going to be a new system and a information highway, and I'm wondering, like, what's the timeline for that being available so that we're all able to really make sure that we're integrating and aligned and ready to go on July 1st, again, so that we can be as supportive as possible to the transition.
All right. Thank you, Stephanie. Dr. Olenyi? You want to take the question of primary care networks, or you want to give it to Jacinta? Jacinta, hii ni yako. No?
The primary care networks are an integral part, especially in terms of implementing the Primary Healthcare Act and moving our care down to the promotive and preventive area. The idea is to be able to have lower level facilities, as in the 2s and 3s. So first of all, the CHPs are the ones who are visiting the homes. That, of course, is not within our mandate. That is within central government, and you know it's a devolved function, so it also has something to do with the counties. In fact, part of the efforts that have been made is that to make sure that all counties come on board. The CHPs have not even been launched in all counties in an active form. Remember, the part of the act was that the contribution from central government was coming, and the county governments were also going to play their role. So this has not been rolled out countrywide, and those are the efforts the Ministry of Health is making to make sure, first of all, they're rolled out countrywide. In addition to that, we've got the level 2 and 3 facilities, which now should be the first point of call in terms of seeking care, and after which, then, if necessary, they can be referred to level 4 facilities. And it's supposed to be strict that if you go to a level 4 facility first, actually, the care is not going to be paid for. You have to follow the system. Now, so the PCNs are being set up, they are being mapped, but that again, you remember we call the issue of the devolved function, is something that the Ministry of Health has to work with the county governments to be able to set up because it's within their mandate. So once the PCNs are set up, even at the point of registration, I've said people are supposed to select those PCNs, and that will also inform when we've got a registration and we see certain regions that are underserved, as social health authority, we might make exceptions and say certain areas you can be able to access a level 4 facility as your first point of call, as opposed to going to a level 2 or 3.
Software.
Oh, the software issue. Now, there's also timelines for setting up the PCNs. It is supposed to be concluded, but definitely it has to be done, hopefully by the time of registration, but definitely it has to be done before we launch the new scheme, so that it is clear how people are moving. The software, that's another issue. an issue because I know it has elicited a lot of debate. Now, there's this digital superhighway, and there's a gentleman called Dr. Ryan Nyotu. He'll be here this afternoon.
He's coming here.
I don't even think I'm competent to discuss that one. But there's a bigger ecosystem that's being designed in which SHA is supposed to plug in. So the Social Health Authority, KEMSA, and other agencies are supposed to plug into this digital superhighway. And again, it's supposed to connect into different databases in government. So there's a health information exchange also. So there's a lot of information is supposed to be gotten. So for us, as a Social Health Authority, this software is really being developed for us. So we're not necessarily people who are the ones who are developing it, but we are making the specifications clear. So us, what we want is for it to be fit for purpose. So that's why this process has taken a little longer. You remember, registration and launch was supposed to be a little earlier. But I've always maintained that between doing it on time and doing it right, if I can do both, well and good. If I had to choose one, I will do it right. So we're going to wait. There's no crisis. Care is still being provided under the NHIF program and financed. So we will wait until we are ready. And once we are ready, hopefully we don't have any missteps. Because if we rush into it, we'll run into problems. So timelines again, by the time we're launching the scheme on 1st of July, and I hope we're able to do it on time, we will be able to do it and do it right. The reason why also we chose the 1st of July is because the kind of funding that we're supposed to get from the Exchequer is not even possible for those funds to be appropriated via supplementary budget. It's a large amount of money. And for us, it is important that we have the money and it sits with us so that as we make promises to you, the money is in the bank. That is important because that's the only way we can be able to pay and develop the confidence, and people say now we're under a new regime and under a new system where payments are coming through and coming through efficiently. But I'm not able to do that. We can't do that as Social Health Authority if again the claims have come in and we're going to beg for money and say we need money to pay these claims. We want at least some significant seed capital to come into our hands from the word go so that we continue paying as we wait for additional funds.
All right, thank you, Dr. Luenyi and the panel. A round of applause for our panel. So, ladies and gentlemen, I just want to inform you that the team at Social Health Authority had written to us asking us to be present today at a meeting to discuss the benefits and tariffs, but we wrote back, and this is also part of our request, Chairman. We wrote back and told them that we have this important event happening today, and we were not able to be present at the two places. We know this is happening at Ole Sereni, where they are looking at the benefits and tariffs. So our request as an association was kindly, if the benefits and tariffs team can allow Rupha to meet them at a different date, even if it is early next week. We can meet them because we've done some work on benefits that we would like to present. And some of the questions raised by some of our members, especially the specialist centers, the eye centers, it will be very important to get that feedback in. So I'm sure for me asking it here, the message is delivered, that we can be allowed as an association because of what was happening today to present to the benefits and tariffs team at a later date this coming week.
That request will be accommodated 100%, and the reason is because you're significant stakeholders, and that's the approach we're going to adopt going forward. Just as a final comment, I'd like to say, I hope today we have gotten a better understanding of why the scheme is there, why the change was necessary, and where we fit in as private healthcare providers in this new scheme. I have said before to other stakeholders I've talked to, let's remember the serenity prayer. Let us have the wisdom, the serenity to accept the things that you cannot change. This thing is past. The courage to change those that you can, and the wisdom to know the difference. So for now, let us look for ways in which we are going to plug into this new system and play our role. For those of you in this room, especially since you are private healthcare providers, the amount of per capita financial inflows into the health sector have just gone up by 150 billion plus. Those are funds which were not accessible before, so that you can tap into, but as you tap into it, remember that the objective is to enhance the capacity of our health system, to be able to provide care for all those people who are not able to access care before. So that is what is important, and even for the doctors, I keep saying, for healthcare providers, by extension, the moment healthcare system capacity rises because of the increased funding, even those additional jobs we are talking about are going to be available. Because if a facility was seeing 50 patients a day, and now they have to go up to 150 courtesy of this new scheme, you will have to employ other people, isn't it? So even the jobs that we are complaining about and the underemployment we have in our sector potentially are going to change depending on whether we manage this right. And I keep saying this is one of the most consequential pieces of legislation in the health sector we have seen possibly in the lifetime of most of us. Looking around the room, in the lifetime of most of us. So we have a choice as to whether, and especially for the Social Health Authority, we have to decide whether we were part of a group of people who took a healthcare system that was working fairly well and dismantled it completely and made it worse, or whether we transformed the health sector in this country for decades to come. And for me as a pioneer chairman, that is what I intend to do. Thank you.
Thank you so much. So now I invite our vice chairman. We have some gifts for you so that you go when you are in a great mood. So vice chairman.
Chairman, I'll still bring you to the podium. At least you have taught me protocol. I want you to present the gift to Shah Chair. Where's my treasurer? You can come. Please. That's just a gift of appreciation. Just to tell you thank you for coming. And thank you for sparing your time to be with us. Karibu sana, Chairman. Just mommy wait. My treasurer here, Banosoro. This gift is for our CEO, the acting CEO for sure. He was supposed to be here. I know there are some things changing. We are still expecting him in the next hours, but we want you to get that gift reach to him. Treasurer, present. Good. Thank you so much. In our tradition, women are given a basket. And so I want to bring in one of our facilities. Did I see Dr. Dennis Kuja from North Rift? You will do this for us. And we appreciate our sister, Jacinta Mutegi. Asante sana. Thank you, and may our good God bless you. Thank you for the time that you have spent with us. Let me also ask for some volunteers to help me clear here and have our podium back. Yeah. Yes. Very good. Thank you, Chairman. Let's appreciate him as he works out. I guess we need to do a small exercise. Watu wa mziki, watu wa band wako karibu, so that we pick up the next thing that is coming. Just play.
With your permission, because people have been sitting, maybe you can stand up a little bit, we do some exercise. Yeah, kindly. Because we've been sitting the whole morning. So, part of our band, we normally do something called music therapy at Kenyatta National Hospital. We offer it to as a free to the children who are suffering from cancer. So, music therapy is considered one of the possible. So, thank you so much for that. So, just stretch out. Stretch out. Take care of your neighbor, unless you have a good lawyer. Stretch out. You turn on the other side, hands up. That's good. Now, just before you sit down, there's a song which is very common. I will make you fishers of men. I'll give you a few instructions. Where there is F, represent female, so it's for women. Where there is an M, represent men, so all men. Tumeelewana? So when we sing, I will make, where there is an M, men sit down. Where there is an F, female sit down. Sawa sawa. Can you do a trial? Yeah, and I've confirmed it with the chair. Those that are going to get it right, you will have your lunch. Okay, let's try. I will make you fishers of men, fishers of men, fishers of men. I will make you fishers of men if you follow me. Oh my, we are going to convert a lot of genders with this one, huh? That was our trial. Now you can all stand up. With the power bestowed upon me now, if you sit down and you are, when you sit down, a female are sitting down and you're a man, you become a female. Huh? Okay, here we go. I will make you fishers of men, fishers of men, fishers of men. I will make you fishers of men if you follow me. If you follow me. If you follow me. Wow. Let's clap for ourselves, huh? Thank you.
Thank you so much. Now I know who to call he and the other one she. All right. Let me now bring in our speakers that are going to take us in the next session. And the very first one will be Dr. Wasuna Owino, who is the Country Director for Farm Access. And he's here to speak to us on a subject of digitization as an enabler for inclusive universal healthcare. So please, let's put our hands together as we welcome Dr. Wasuna to come and speak to us.
Good afternoon. Good afternoon. Yeah, that's better. Okay, my name is Dr. Wasuno Wino. I'm a health economist by profession and currently country director for Farm Access. And Farm Access is actually headquartered in the Netherlands. We do have 4 offices in Africa. That is Kenya, Tanzania, Ghana, and Nigeria. And our mandate is to support countries to transition towards inclusive UHC. So the topic for discussion today is actually on digitization as an enabler for inclusive UHC. And this actually touches on what the previous speakers have actually been able to mention. And as we can see in the next slide, I would just want us to look at the situation where we are in Africa, and then later come to Kenya. So if you can see the statistics that we have there, Sub-Saharan Africa carries 21% of the global disease burden, but only 2% of the global healthcare financing. And that's something which is very, very critical in terms of bringing in inequities in the system. So you can see that the per capita health spending stands at about $74, and compared to other lower and middle income countries, which are presently at 119, while on average the health insurance cover is 6%. 11 million people in the region are actually pushed into extreme poverty due to high out-of-pocket spending, where 37% of the population forgo healthcare. That is the picture from the Africa region. Coming to Kenya, 21.1% of sick people do not seek care, and that is because of high cost of care. The health insurance coverage has improved. Currently, is estimated at 25%, but of course there are wide disparities between the urban and rural areas. The out-of-pocket spending is estimated at 27.7%, which really means that these are the number of times that you really need to get into your pocket to be able to provide a care, with 7.1% of Kenyans incurring what is called catastrophic health spending. And this is something that we are all familiar with. People selling their assets up to the last one to be able to get their family members actually getting treated. And at the moment in Kenya, we find that the private healthcare providers actually provide about 54% of care, and that is from about 49-50%, which really means that the share of the private sector is actually increasing. But what is important to note in this country is that the private sector is the one that really drives the innovations, and that's something which is very, very key. But the private sector suffers from underinvestment, which is estimated to be about 25 to 30 billion. So there is underinvestment in the private sector. So what are we saying? The health system is actually characterized by a downward spiral of poor supply and demand that lead to inequities. And in economics, you would actually indicate that we are actually tied to the vicious circle of low supply and low demand. And it's interesting to see many institutions trying to provide banking, and we find that banks are actually unwilling to invest in clinics, and the clinics cannot actually improve quality of care with limited financing, and this actually drives patients away from care. And therefore, as Rupha, the question is, how do we really address this situation? Now, if you look at the next slide, what we are saying here is that UHC simply cannot be achieved if we continue to do the same things as we did 20, 30, 40 years ago. And I think this has been alluded to by the previous speakers. And if we look at it globally, what we are saying is that if the global trend continues, the number of people that will be unable to access care are estimated to be about 5 billion by the year 2030, and would actually require annual additional spending of $1.2 trillion. That is, if you look at it from a global perspective. And so comes to the essence of our discussion today, which is actually presented in the next slide. How can we actually use mobile and digital technology? Because it does have potential to transform the countries in the region than would initially have actually been imagined. You may not believe, but sub-Saharan Africa is much more advanced in technology and especially in mobile payments than even the advanced countries like America, where many of us want to go. 10% of the GDP transactions are actually through mobile payments in Africa, and this is actually compared to 7% in Asia and 2% in Europe and the US. And kudos to our M-Pesa. Everybody in the village can transact even at night, even on bed, am I right? And we have 11 countries have over 50% mobile phone penetration, and for Kenya is 113%. Now, what that really means is that, maybe before I ask that question, how many of you have more than one SIM card? Just by a show of hands. Somebody saying all of us. That's very right. The SIM mobile penetration is actually about 30%, which really means that on average, the Kenyans have 2 SIM cards. Now, have you ever thought of how you can take advantage of that to be able to enhance care? In terms of access to information, in terms of exchanging information, which you can actually use for promotive and preventive care, connecting to providers, connecting to payers. So there's really a lot that we can actually do with that level of SIM penetration. And again, a bit was discussed in the previous session. The government has actually taken digitization as a priority. And we do have efforts going on in terms of developing the Kenya Digital Superhighway, which is actually anchored in interoperable digital data exchange. We aim to revitalize our primary healthcare networks through digitization. We aim to promote e-health, m-health, telemedicine, e-learning. And we also have the Data Protection Act in place and the Digital Health Act in place. And this really does provide a very, very big opportunity for all of us to be able to plug into the superhighway. And the question is, how can we actually use that enabling environment to be able to enhance care to our population. And that's something which is very, very key. And this is actually where Farm Access comes in terms of supporting or using the enabling environment to transform the health systems to inclusive UHC. So Farm Access has actually been working with governments. Maybe the next slide. The next one. Yeah. So Farm Access has actually been working with governments to make inclusive health markets work by unlocking the power of connectivity and data to leapfrog development in the respective health systems. We have set up organizations that provide health insurance so that people can pay for the care that they need. We have introduced quality standards so that people know they will get the care they expect. And by providing loans, I'm sure many of our customers are here through the Medical Credit Fund, healthcare facilities can now improve the quality of the care they offer. And through the mobile and digital technology, patients can have better care. And in this case, we're actually bringing in the patient centricity in terms of provision of care by bringing the patient right in the middle. So I would like to deep dive in just one of our two interventions to show what this has actually done to us. And this is by looking at, one is that how have we actually leapfrogged the universal health coverage in one of the counties, and that is Kisumu, and also how we have actually supported mothers to be able to have safe pregnancy journeys. So for the next slide, the next one, yeah. So here we work with a partner who is MTIBA. I'm sure they're in the house. Where are the MTIBA folks? MTIBA? Okay, they must be somewhere. Now, we actually work with the MTIBA, which is actually, it was actually a product of Farm Access, but it has actually had its own life. It's now being implemented by CarePay. So we have used that platform to simplify the life of every stakeholder in the health insurance ecosystem in Kisumu. Now, MTIBA really connects three key actors. The first one is the customer or the client, and through this, we make the healthcare cover products more affordable, easier, and transparent. And for the providers, as you, we actually make sure that the payment to hospitals become easier, faster, and provide access to affordable financing sources. And for the payers, like in this case, it could be the government or individual payers, we make sure that administration becomes easier, cheaper, and better, and we decrease fraud through real-time data, insights, and analytics. And one of the critical features of MTIBA, I'm sure many of you are on MTIBA platform. How many of you use MTIBA when you seek care? Some are half, so is that half? How many of you use MTIBA? Okay, good. So that's quite, as a provider. Okay, oh, that's good. So one of the key things of MTIBA is that everything is actually on your phone as you seek care. You have real-time insights in terms of the benefits and limits, and every time you go to seek care, if your balance was actually 200,000 and you have utilized 10, it will show you are reducing balance until it's actually zero and you can load again. It also provides, it gives you the ability to save. It has a savings wallet that you can actually use. And for Kisumu, what we do is we encourage the population there to save in their wallet, and that money is actually ring-fenced. And it can only be released when you seek care, and you cannot buy with it anything else. Of course, it also does have the 24/7 dedicated customer support, which is very, very important. One of the key issues that we are discussing in the morning is the issue about claims adjudication. MTIBA does have that function, and the platform automatically conducts several checks. One of them is whether the diagnosis matches the treatment, which is very important for us. Then whether cost of the billed item is in line with expectations, and also whether the claim is not a duplicate of a previously submitted claim. And as we talk about this, we know this is Kenya. So MTIBA does have that at the background, and it is very, very important. So in Kisumu, for last year, we actually supported 42,650,000 households, which translates to about 117,000 lives, who are actually onboarded onto the Kisumu Health Solidarity Cover, which is actually called Marwa, with the NHIF as the underwriter. And as a result of that, we are actually able to get a lot of lessons through this, which we could also share with the Social Health Authority, which I think is really quite key. So through MTIBA, we are able to do socioeconomic profiling of the population, and it does have a means testing tool, which was also used during the pilot stages. Now, when it comes to premium payments, we are able to use the MTIBA platform. And when it comes to patient care management, and when it also comes to claims management. And through this, we are actually able to enhance efficiency in Kisumu. For example, through capitation, we're able to increase the capitation about 10 times. And this is actually additional monies that the county health facilities did not really have. And that's something which was actually very, very key. So that is actually one of the products that is very, very important. And just to give you a feel of the dashboard that the county has, maybe go to the next one. Yeah, that is a county dashboard that is generated by Marwa, and it really gives you real-time information in terms of the inpatients and outpatients that you have, the number of visits, the billed amount, the claims rejected, and as you can see here, we had 3.28% claims rejected. It really gives you a lot of information, which you can actually use at your fingertips to be able to make decisions. And what you can see from that circle there is that bulk of the billing was actually in lab, which was 46%, followed by consultations, which was 27%, and then drugs, 23%. So you can actually be able to get much more information through MTIBA. Now the next is having a focus on the women and children. Now, women and children are actually major consumers of care. And if you look at even morbidity and mortality statistics, once you really concentrate in that population, then you really be able to cut down on your cost. So we work with the county, and of course this also includes Kisumu, to overcome financial, quality, and behavioral barriers faced by women during their pregnancy journeys towards better maternal and neonatal health outcomes, leveraging on digital technology and pushing for the principles of value-based care. So, can we go through the pregnancy journey? And then that reminds me of that song. How many of you sat down and how many of you stood? Good. So, for the pregnant mothers, navigating the care system is complex, as many different stakeholders are actually involved. You do have, of course, the client, the mother who is there, and you have got the foremost stakeholders, where you have the providers, you have the midwife. There are also issues of mental health, so you need to get attention there. you also need a nutritionist, and you also need a pharmacist. And at the community, of course, your partner is in the house there or somewhere in the neighborhood. And you also have got advisory committee in most cases. And, you could be in chamas and all that. So it's really a very, very different complex. So what you can actually see here is that at the moment, the care provided to the pregnant women is actually fragmented. And you see that you actually visit these people at different times. You actually discuss with them issues at different times. Suppose we connected all these groups using some technology so that the pregnant woman does not have to get into a matatu maybe 26 kilometers away, then come back just to find out she does not really have the nutrition that she really needs. And this is something that we have actually tried to address at Farm Access in terms of how can we actually reduce this type of fragmentation, where we bring all the providers together through an interoperable data exchange. And given that you are in this space, you'll be hearing a lot in terms of interoperability, connectivity, and all that, which is really very, very critical. So how do we bring all these different actors together to be able to improve on the health outcomes? So what we actually aim to demonstrate is by enhancing collaboration of healthcare providers through a digital platform and connecting the patients to care and support, we can actually reduce the fragmentation and complexities that the mother really goes through. And through this, we do anticipate to obtain improved health outcomes. And our critical point here is value-based care, where we are really interested in, through that impact, how is the health of the mother? How is the health of the baby? How is the nutritional status? So that is really what is very, very critical, rather than the mother just going for the services. And remember, through digitization, you can also profile the high-risk cases which really require attention very fast. And for counties that could have like a risk equalization fund, that could be something that is very, very important. And therefore, we actually try to see how we connect this pregnancy journey right from conception to when the child is actually getting immunized. And if there are very high-risk cases, then we're able to profile those and obtain financial support for that. So those are just two of examples that I wanted to share with you. So what do we get out of all this, especially when you are dealing with digitization? I think one, the level of inefficiency in our health system is quite high. It has been at 30% inefficiency level, which really means that out of every $10 or 10 shillings that we give for health, only 7 goes to health. 3 is actually wasted. And therefore, one of the lessons with digitization here is that we can actually do more with less. So instead of going out fast to ask for money, let's make more efficient use of what we really have in our pockets. And again, there were questions here in terms of the different products that we have. The experience we have actually had is that it is actually important to move towards a pooled financing system rather than a fragmented system. And the chair did really give very, very good and valid reasons for that. And if you just take an example of the eduafia, if you have a child in your house who is, at the secondary school, those are covered under your cover. So, which is this other insurance you're saying that you are going to cover eduafia for them? Again, if you do have a lady who is expectant and we're using Linda Mama, what happens to this other card? So you can see it's a lot of wastage. Because for the same person, you're actually having more than about 5 covers. Why can't we pull everything together? And that's something which is very important. And therefore, we actually need to adopt systems that promote innovations. One is on the digital technology and data use. And for us, and for your facilities, digitization is the way. And we don't have any shortcuts around it. And we also need to use digitization to incentivize providers for quality. I know there's a session on provider payments. I think that's something which is important to have. And we also need to tap on private sector innovations, which is actually very, very important. And lastly, we actually need to get serious about addressing waste and leakages. And the success, I would say, of the new scheme is actually going to be dependent on the claims adjudication. If we get it right there, we are quite okay. And if you are also able to provide quality services as and when people need it, then we'll actually get it. Otherwise, that's all that I had to share with you. And I do hope that in our journey, we'll be able to bring in as much digital technology as possible, and especially taking the opportunity provided by the government through the development of the super highway. Thank you.
Thank you so much, Daktari. Let's appreciate him again. Just want to request that in the interest of time, a lot of time was spent in the morning, but if you can allow me, we do this session before we go for lunch, it will be good. The good thing with this session is that we are having very, very exciting presenters. You will like it. One is the one I'm going to bring next, the Director for Safe Care, Sister Millicent Olulo. You will love the English as much as you love what she's presenting. Karibu sana. Let's appreciate her as she comes.
Asante sana. Thank you very much. Good afternoon. Good afternoon. I know I'm standing in between you and lunch, but I hope to make it very interesting, and I'll make it very short. So my name is Millicent. Besides working at Safe Care, I chair the health regulations, quality and standards at the Kenya Healthcare Federation, and I have my chairman here. First and foremost, as I start, I want to request all the ladies to stand. All the ladies, please. And I just want to say, oh, Brian, you are a lady, you became female during that time. And I want to say, I don't know if we normally watch America's Got Talent. Stephanie, I'm sure you watch that. And some of the ladies in the house. Rupha today has gotten a golden buzzer. This was a golden buzzer. And where I come from, the women celebrate. So the women, can I have an... Thank you very much. Thank you very much. You may be seated. This is a very good step and very good progress for Rupha. We really appreciate the inclusivity is about leaving no one behind. So you're in the right path, and we really appreciate. So I want to talk about empowering futures through quality. It actually ties to your theme. How are we empowering the future through quality? And just to begin with, I want to ask two people to disclose for me their revenues. 2 people in the room. I can see already someone disclosing their revenue. Can I have 2 volunteers? Is there anyone who wants to volunteer and disclose their revenue? Why don't you, I have a gentleman with a hand up. Why wouldn't you disclose your revenue to me? You're saying? For security reasons. He's not able to disclose his revenues for security reasons. We are all entrepreneurs, but he's not able to disclose his revenues for security reasons. And I think
so we are a small facility at around 26 million turnover. You wanted?
Thank you very much. Let us clap for him. And one thing, let's clap for him. I appreciate that I have earned your trust. I've earned your trust and you've been able to share that with me. Why do people hold information? Why do people decide not to do something? It's because of trust. You do not know what someone will do with this information. And that is why we are talking about how does quality build trust within our facilities. And what has been seen is that poor quality of care actually results to more death than lack of access to care. If we have everyone, we saw the chair of SHA here, if we have the entire country, everyone in Kenya is actually insured and has access to care, but the care is poor, will we have the right outcomes that we want? Will we have people trusting the system? And the answer is no. I can confidently say that. I've walked this journey, I'm walking this journey. The answer is no. And a Lancet study that was done recently in 2018 also brought out that you can see 5 million people, that's quite a huge number, are dying because of poor quality, whereas only 3.6 are dying because of lack of access to care. And the big question is, how do we shift that? How do we shift that and ensure that this can go? Please move the slides. Please move the slides. Go to the second one. And then the third one. So one of the things that we have seen is that health facilities, they have a challenge. And you can attest that the obstacles to improve quality of care can be overwhelming. It's not a one-off thing, but it's a journey. And why? Why exactly do we have these challenges? It's because of lack of knowledge and resources. It's because of lack of guidance. Where do I start? And because quality is not perceived as an opportunity. At times you find that leadership do not foster it. But we appreciate that the current leadership is actually fostering quality. Please move to the next slide. And with that, as Farm Access, we partnered with Joint Commission International and Council for Accreditation in South Africa and came up with the safe care standards. The standards that are really contextualized to our local systems in different countries where we operate, because as I speak, we are in 26 countries as safe care. And one of the things I want to tell us is that quality has no nationality. Quality has no private or public. When you're sick, all you need is quality of care. And we decided to walk this journey together with us in a stepwise way. Move to the next slide. In a stepwise, progressive way, such that it's not a pass or fail, but it's where do I start from? Where am I? Like if you're in a hotel, if you're in a 2-star hotel, you know what to expect. If you're in a 5-star, you know what to expect. You'll be asking for soup, you know the hoteling services, how everything is. The vice versa is what we are using for healthcare. And this is not in terms of size, but this is in terms of quality. You can be a facility that is, as most of you may be, but you're still offering an Aga Khan type of services and at an affordable level and for primary healthcare providers. Move to the next slide. And then move to the next slide, as I've promised you that I'll make it very fast. So one of the things that we do is we have used the power of digitization. We saw everyone has a phone, and we have even 2 SIM cards. If we saw M-Pesa do it, in the financial industry and bringing the inclusivity. Why not do this in healthcare? How can we democratize healthcare such that as patients are voting, they choose, why should I go to Brian and not to Mohammed? It's because of the quality of care. That then enables the clients to vote with their feet. So SafeCare is using a lot of digital platforms to be able to improve quality. One of the things we are doing is we have self-assessment. There's an opportunity for self-assessment, and there's an opportunity also for assessments by independent teams. And we have quality improvement plans. All in your, you can access them in your phones. You have dashboards and gamified support, such that it's an interaction and the stickability. And this is what we see, that even as we are seated here, at times you find that your phone just calls you by name. Even before it rings, you feel like, I want to pick my phone. Why? How can we use it to advance quality, such that the nurses and all the staff at the facility can be able to improve the quality of care, and as a network, giving us an opportunity to benchmark and cross-learn with each other, that how can I benefit from a center of excellence and know what this other person is doing better for me to be able to improve. Next slide, please. So the standards are internationally accredited, and they are relevant and applicable to our context, and they're quite holistic, covering all the services, management and leadership, covering the primary health care, covering all the clinical care, and all, including hoteling services that we find within a facility. And the key focus is to see how can we increase more clients, how can we drive contracting and access to investment opportunity. Please look at quality as a way of driving contracting and access to investment opportunity. Move to the next slide, please. Next slide, please, in the interest of time. So to date, as Farm Access, where are we? So this is where we have been able to reach at SafeCare in terms of assessments in the country. We can say actively in Kenya, we have over 1,356 facilities. We have done over 4,000 all-time assessments. We have trained capacity, built capacity of assessors to be able to conduct this. I want you to really remember building the capacity of assessors, and this will be important to us. And we have over 1.6 million actually visiting this facility. We partner with counties, we partner with private sector organizations. I believe we know the likes of the KMET, who is also a member of Rupha, Stralid, and the CRS, the Catholic Relief Service. We have also worked with organizations and hospitals such as the Aga Khan, MATA, AAR, Kiwa International, and Equity, one of your other members, Penda. Thank you for being our faithful partner over the years as well. So move to the next slide. There's an African proverb that says, if you want to go fast, go alone. And if you want to go far, go together. And in that spirit, as SafeCare, we saw that the field is there, there's so much to be done, and we cannot go it alone. We believe that we need quite some partners to be able to onboard and to work with to be able to achieve the quality of care that we need in the country. That's why we are working with such partners, including an invitation to Rupha as well. Again, if you look at people like Maya Angelou is very well known to us, Maya Angelou. And she always says, you can't really know where you're going until you know where you have been. You cannot know where you're going until you know where you have been. And we can attest to that. We know where we are coming in terms of even health financing. I have the questions we're asking on NHIF. We know where we are from, but very positive feedback from the chairman. Where are we going? And where can we be? So this has been our journey. Move to the next slide. This has been our journey as SafeCare. We launched in 2011 in Kenya and Tanzania. We have worked with several partners. Several people have been part of this journey, working together with us, the likes of the Population Service Kenya, Mary Stops. We were part of the Africa Health Market in Equity. And we also partnered with NHIF, interesting. And this is an important point to note, that we trained over 100 benefits and quality assurance officers, and they were using SafeCare. We are hoping when this authority comes in, these people will be able to feed into that new authority that was being discussed here, that will be looking at quality. Again, we launched now the issues of how can we ensure that we are operating within the context. We all know that KENAS is the only enacted institution. KENAS is a Kenyan accrediting body that can accredit someone to do certification of facilities. SafeCare is KENAS accredited, and it has accredited Farm Access as a conformity assessment body. So when we were accredited, we saw that, yes, besides doing it alone, would like to work together with many of us and scale through partners. Because for you to sustain and to be able to grow, you cannot grow alone, as I've alluded in the previous slide. And move to the next slide. I want to allude to our value creation model. Our value creation model looks at, we use biomimicry, following the nature. How does one grow? That you can start from 1, 2, 3, 5, and you keep growing. And in the long run, we hope that once we work with several partners, we'll get to even over 10,000. So as we want to increase impact and reach, we reach out to several partners and say, can we work together? And can we increase this together? Those are some of our licensing partners that I had mentioned. Move to the next slide. I want to allude to something that's very strategic happening here with us in Kenya. And you all are aware about Shifsha. You heard what he was saying. There's a shift. And the shift means that change is coming. And the change that is coming is interesting. You heard the chair say that they will not be the ones doing the certification and assessments of these facilities. But if you look at Article 33, it states that a healthcare provider in health facility seeking empanelment under the Act shall make an application to the body responsible for accreditation for quality of care in the manner prescribed by the Cabinet Secretary. What does that mean? There are regulations that are under development. We know about the role of KHPOA, about professions, but there are regulations, which means there will be authorities, conformity assessment bodies, that will be doing the certification. So if you allow me to refer to the Bible, as John the Baptist will say, prepare ye the way. So this is in terms of us saying, can we prepare the way and ensure we are aligned? I always say opportunity meets preparedness. If you're not prepared, opportunities can easily pass us. And that's very important. There is an opportunity for Rupha to become a SafeCare licensing partner. We've been discussing with your leadership. Your leadership is very progressive, and that is something that we really, really appreciate. Some of the benefits that we see, if you join the team that is working with us, it will be, you'll be preparing for SHIP and Parliament. Economies of scale will allow members and facilities to save up to 50% on certification, on working on the quality journey. And then the issue of brand image. SafeCare is a mark of trust. You will be able to improve the brand image. We will also be able to improve the clinical and business outcomes. I always say, why quality? It's about clinical and business outcomes. Again, you will be able to build capacity of healthcare workers in quality improvement. And the assessors that I was mentioning and talking about, some could even be coming from your facilities to be able to improve that. And just as I finish, allow me to tell you one story. As I've been in the sector for 25 years, I was working in a hospital, and we had one person who was in the laboratory who used to work in that very big hospital. Then one time he collapsed, he was sick. And when he was sick, he just fell down and had to be admitted in the very same hospital where he was being offered the care. In the process of getting this care, he actually goes and he needed transfusion. So they rushed to the lab quickly where he was working, and they started transfusing him. So he gained consciousness. Then when he gained consciousness, he woke up and found that he was being transfused. The guy collapsed again. He just chewed a blackout. He couldn't believe. Why? Could we think, why did this guy collapse? And he was partaking of services in his hospital. Yes? He was not screening. Very right, Dr. Brian. The guy was cutting shortcuts, he wasn't doing grouping and cross-matching, and he didn't know that one time he will be the one partaking this very same shoddy quality that he was offering. So he was so shocked, and all that blood had passed through him, and he cut the shortcut, and he had to consume this blood. So as I finish, I want to ask you, why quality? Let's not only think it's for Wanjiko. You can become Wanjiko at any given time, and you can partake this very same quality that you're offering. Thank you very much.
Thank you so much, Millicent, for the Queen's English. Please, the owner of KDL 331V, kindly attend to your car. Right. Very interesting again. Our next speaker, you won't blink. I promise you. She's very interesting. Actually, when the chairman met her, he came and told me the story, and I began to be optimistic up front. I'm sure that is your story. I want to bring to us our sister Lillian Gashoki, who is the founder and CEO of Dream Credit Limited, and she is going to speak to us about financial cushioning for healthcare facilities. Ini pesa. So put our hands together as we welcome our sister Lillian.
The chairperson of this great association, invited guests, ladies and gentlemen, good morning. At least you are awake. I'm so happy to hear good afternoon. I'll try as much as possible to keep it short and sweet, but above all is for us to learn one or two things. And the reason why, and even as the questions were being asked, as we look at this transitioning, we are still entrepreneurs. There are still bills to be paid. And I'll be trying to share my thoughts in that, but I must appreciate the role that you play in this industry. And as this great lady was going through the last story, it's always good to do good, because you never know what might happen to you. So I'll not wear the hat of being a financier. Yes, we've been in the industry for the last 15 years and partnering with the health sector, but I wear the hat of looking at how do we cushion these enterprises even through this transition. And when you start even thinking about the challenges, NHIF issues of payments, the audits come up, But on the other hand, you're also paying the employees. And I say that with a very low voice. The suppliers are still being paid. Yeah, procurement is happening. And I'm told in hospital, there are things that have to be provided, like gloves, you have to use that every day. You have to use masks, syringes, just to name but a few in this industry. On the other hand, for the suppliers in this industry, you have to clear goods at the port. At the same time, patients are knocking, and you can't say we are waiting to be paid for us to treat you because we still have a human face. We've seen a number of hospitals getting closed. We've also seen some outlets being closed, and it's for one reason. You have money in the file, but you don't have the liquid cash to meet the day-to-day operations. And yes, this is a new regime, which we have to align. But as we align, that also affects our operations, because that's something we also need to look at. As much as we hear housing levy, we have teams that are working with us. We still have to comply, both as a corporate and even as we support the employees to also comply. We hear NSSF Tier 2, which affects our businesses. Then we still hear the SHA. So all these affect our operations. On the other hand, I know we could have received some letters, interest rates going up. Is it? Still in the same environment, the forex exchange, the foreign exchange, and this affect on procurement, because the suppliers, when the dollar rate or the euro rate or the foreign currency exchange rate went up, it meant prices have to be revised. The cost of living going up, and we've also seen a lot of joblessness. But this is not the time to go like, this is the end, what do I do? Because we've been put in this industry for a reason and a purpose. And allow me to share a short story, because with all what is happening, what next? And this calls for financial reorganization. And I just want to share a short story of one of the health facilities that approached us about 3 years ago. And the challenges they were dealing with, one, debtors list. As much as there is the government part of it involves individuals and also collecting money from the insurance companies. And this saw this business owner having delayed paying of the workers, not able to pay rent timely. At some point, the auctioneer's hammer was at one of their branches. And when we trying to analyze, this great entrepreneur had a number of title deeds. If I was to describe them, there would be an album of title deeds. But while looking at that, from one school of thought, I'm told we are trying to raise the number of title deeds of properties so that we can have securities for loans. But again, when we look at our operations, then we'll be able to see, is it the right way to go about it and be sharing that. This particular entrepreneur was not also able to pay the financials listed in CLB. And I know as business owners, when you are listed, the first thing you ask, what next? But I always say it's not a death sentence. However, when we, after all this analysis, we gave a recommendation. One was to create a collection team. Because yes, the entrepreneur was very busy up and about looking for payments at times, also trying to oversee operations, but you'll agree with me, as a business owner, there's so much you can do. Not forgetting that this particular business owner was also a doctor and also attending to patients. The collection team win was they were able to connect with the insurance companies that had not paid. That means they could be able to generate money from the value chain by collecting payment, and also in terms of negotiating for better payment terms with the insurance companies. And through this, even if we were able to finance them with operational working capital need, we saw them retiring that loan pretty early, because remember, you're collecting more. And on the other hand, they were able to actually clear the financial who and actually listed them. And with that, their name was dropped off from the CLB. And the other question is, What else can we do to try and cushion our business, over and above looking at our operations? One, avoid utilizing working capital needs for business expansion. And why do I say so? Assuming my business operational needs every month requires, say, 10 million, depending on the size of the facility. It may require 20, it may require 100, depending on the size of the facility. We know very well, for you to invest in an outlet, and that outlet actually breaks even, takes a bit of time. Meaning if we move our working capital money, and that's the money for paying day-to-day running of the institution, paying suppliers, paying workers, just to name but a few, not forgetting the tax man is waiting come next month. So there are a lot of costs that has to be addressed. So the question is, if the money is pushed towards business expansion, what happens? The likelihood of getting to a cash crunch is very high. And sometimes I'm so sure you're looking at me and wondering, am I killing the dream of expansion? No, I'm not. The best route to go is borrow or source for capital, either from a financier or else look for additional capital, and it can be through equity funding or debt funding, as the case may be. The other thing is diversifying the patient's portfolio. I know there are quite a number of levels that have been discussed in terms of the healthcare space, but what we've seen, the hospitals that have greatly been affected are the ones who are shy of 100% on the NHIF counts, and that's the real reality. Yeah, some of these hospitals didn't close because of anything. They are old. In books, they are rich, but in reality, they have rich money to look at. And the question is it time to look at it differently? Is it time to look at part of the money coming from other insurance providers, as well as we look through this transition? On the other hand, I know there are some facilities, we also see individual, depending on the specialized service they are looking for, could you negotiate in terms of a bigger deposit if you are giving debt, and also have a collection team to avoid you running into cash crunch. The other bit is avoid using working capital for illiquid assets. And why is that so? And I just want to give an example. Assuming that I'm to be paying 50 million for the sake of this example, and out of that, my immediate creditors need, say, is 20, and I pay, and I'm very, very grateful. But the 30, I decide I need to buy more land to create more security. And while doing that, it will mean that one will be financing the business now from debt, and that is loans. I'm in that industry, but the joy that it gives me is when I fund for business expansion or acquisition of assets that will bring cash to the business. Because so long as we are having working capital crunch, you as a business owner, you look at supplies. We also have a business that we are managing, but we need to keep on asking, what else can we do in terms of avoiding illiquid assets? What are these illiquid assets? Assuming my 30 million, I went to Nanyuki and bought land worth 30 million. And I say, in this city, I have land in hectares, but I'm cash poor. I'll not walk into this hotel and tell them I have a huge title deed. Please serve me a cup of tea or even lunch that we are going to have. So more than ever, it's time to really look at cash and keep on asking, how can I extract as much as cash for business? And putting in money to an illiquid asset that you are not going to develop, say, in the next 10 years, but remains with you knowing that, yes, I have this asset, and becomes what I say from the area I come from. When people are seated, you have these pieces of assets, you know? You have a speech to talk about. Then the other bit is have diversified portfolio, and I want to just talk about one of them. Assuming that part of the investment over and above business, particular asset, you are able to earn money in terms of the interest after every 6 months. And at the same time, when you earn that, you can still use the bonds to secure overdraft. Remember, interest, withholding tax on those bonds interest is final tax. On the other hand, when you're looking at your business, you're saying, if you pay the 30 percent corporate tax, the government is also paying you something. Currently, the rate is 18%. Investments. I always like looking at a business and evaluating it without emotions, because if it's not working out, then something needs to change. It's not a question. Sometimes some outlets, it's also going to let go as you advance. And why do I say so? You couldn't be throwing in so good money and you still it doesn't work out. But again, what else can you do? Involve professionals to assist there. Then always track performance and ensure you can change what needs to be changed. My final thoughts. It's good to explore collaborations opportunities, especially across the East African region. What will you be trying to address? Cushion yourself against the exchange rate. You'll be paid in dollars, and on the other hand, Kenya, we are more advanced, and I say this with a lot of humility. And that poses a big opportunity for us. The other thing is dispose of idle assets with no emotion of attachment, because sometimes we feel things gonna change. How will people think of me? But remember, when you go to your house, you are on your own. This stress level is one that you've even been able to lobby the government. When we see the chair sitting here and sacrificing the number of... And I know, I acknowledge you don't do it alone. You have a whole secretariat. We say kudos, because progress starts from the voice of one person. And we can see the numbers are really growing. The other bit is going to continue aligning ourselves, because change is inevitable. And even if we keep on saying that this one is unfair, this is one unfair, the registrations are in place. But what can we do? We can participate, being part of the people who are revising the tariffs, so that our interests are really taken care of. Consider diversifying your own investment to cushion your business. And above all, look at the efficiency in your business. I love the bit of accreditation, because that will be able to have checks and balances in our own operations. And I know the chairman mentioned there will be gifts as he was starting. And I have a gift for 1 hour complimentary business cushioning strategy session for the first 10 interested people. You fill in the forms at our exhibition booth. We are exhibiting as Dream Credit Limited. There are forms there. You can indicate your interest, and I'm being glad enough to give my time as tithing. As Dream Credit, we reassure you that we are committed to continue financing your dreams for a better life. Thank you very much for this opportunity, and wishing you all the very best as you continue impacting positively in the health sector. Well done. Thank you.
Wow, that's awesome. These are the people you meet in the corridors and you end up with 10,000 in your hand. I want to bring in our next speaker, but kindly allow me to acknowledge the presence of Dr. Nathan Morogo and our mama, Mrs. Morogo. Thank you so much. Dr. Kanyenje Gakombe is also in the house, Chairman KHF. Please appreciate Dr. Thank you so much. Now, we'll be doing our last speaker, and then I'll be handing over to Mohamud for the next course. We want to hear from one of our great partners, Universal Corporation Limited. Dr. Safik is in the house. Please appreciate Daktari. Karibu sana Daktari.
Good afternoon. Okay, I need my presentation. Just give us a minute for the presentation to be put up. Must be easier. Should fit.
This is better to tell you next slide.
All right, that makes sense, yeah. All right, so thank you so much. I know everybody is hungry, but I'll not be too long. I think the whole day today we have talked about quality healthcare. And what is quality healthcare without quality health products? So that is where we come in as Universal Corporation Limited. We are a global pharmaceutical group. We will go through our history. So just to say one thing is that our focus at UCL, is a short form, is to identify and develop a niche of products that create differentiated value and in the global generics sense. So this is a brief history of Universal. We started in 1996, and that was in industrial area. Towards 1998 is when we now started construction of our new state-of-the-art plant in Kikuyu. And towards 2005 and 2008, we received some investment from FinFund, which allowed us to now go the full mile towards the WHO pre-qualification status. UCL currently has a presence in 22 countries in Africa. In the year 2016, we merged with Strides of India, and currently we are one of the very few WHO PQ plants in Kenya, in Africa rather, and the only one in Kenya. And we have successfully maintained this status for the last 12 years. So you can see some of our images. The last is now what the current plant is in Kikuyu. So if you look at, I'll not go through most of the slides because of time. So now UCL is also part of the Strides Global Growth Strategy. So we have 27 plus years of experience. We have a revenue of more than $30 million across the region and different products. We have more than 100 plus products across different dosage forms, that is tablets, creams, ointments, capsules, and sachets. We have operations in almost 22 different countries within Africa, 400 plus employees, and we have 10 plus approvals, including the WHO approval from Geneva, UNICEF, PSFM, PICS, and amongst others. So what is our vision? To be a leading partner in providing healthcare, quality and affordable healthcare to Africa and beyond. Focus is from Kenya to East Africa, COMESA, and then the rest of the Africa. Mission to provide a high quality healthcare products to more people. And our core values, quality, integrity, teamwork, customer focus, and innovation. So what is our strategy? We have a diversified business with in-market for market strategy to cater for the African territory. We manufacture dosage across tablets, capsules, ointments, creams, and powders. We have a total capacity currently of over 3 billion tablets annually. We can manufacture 160 million capsules, 95 million sachets, 20 million liquid bottles, and 12 million creams or tubes. We have a good track record of global compliance with regulatory accreditations. So this is just a snapshot of the capacities, what I mentioned. Yes, we are approved by the Pharmacy and Poisons Board in Kenya, NAFDAC, some other organizations, TMDA in Tanzania, MCAZ, etc. So these are some of our WHO PQ products. I'll just end with that. So we have products artemether lumefantrine tablets, which is approved by WHO. We have the ARVs, tenofovir, lamivudine, dolutegravir. We have also another ARV, lamivudine, zidovudine with nevaripine, and efavirenz. We also have now sulfadoxine pyrimethamine dispersible tablets and a co-blister with amodiaquine. So these are some of the products that we have manufactured locally and are approved by the WHO Geneva. So looking at that, I think that's the slide from our side. I think I didn't want to take too much time. But in terms of Universal Corporation, I think you have a very confident partner in healthcare. All our products are available to the right quality and to the right cost. You can visit our booth you will be able to get more information on how to get the products and how we can partner towards the universal healthcare. Thank you so much.
Thank you very much, Dr. Shafiq. The next session, I'm sorry we are responsible for no lunch, but bear with us. The next segment is a process of you getting access to credit. So before you go to lunch, be sure you have a path to access credit. So I'll welcome the panelists. Dr. Millicent and Dream Credit, and Dr. Osuna. Karibuni. Sorry, Dr. Shafiq as well. You're part of the panel. So members, kindly prepare your questions for the team. You have Self-Care, you have Dream Credit, all are ready to give you credit, but do you know how? Let's ask them. So, Dr. Shafiq, I think he's ready to give you what is required once you get that credit. Thank you.
Thank you, Mahmoud. I think I will kick us off with a question for everyone. So the first question is to Dr. Osuna. In what ways is it possible for you to work with the association to expand the reach of MTIBA? I think some of the providers here are already using MTIBA as providers. But generally, the impact, there is still opportunity for growth. And just so, to what extent can you work with us? What are some of your thoughts on that? And how possible is it for us to develop, let's say, a Rupha wallet that is attached to MTIBA and can work as an alternative way of paying for services? That is one for Dr. Osuna. I have a question for my good friend Lillian. So you talked about providers who are 80 to 90% dependent on NHIF. And some of these providers have actually gone out of business, especially during this transition. Do you have some thoughts on how providers can come together and change our dependence on NHIF? One of my experiences, with the association has been there is too much reliance on NHIF, and I think we are going to have too much reliance on SHA. It is almost as if all of us in this sector have an obsession. We have an obsession with the we had an obsession with NHIF. We are now building a new one with SHA. Now, the problem is, and I can see this from my interactions, despite everything the chair has said and in the morning, I know he said one thing that people missed, that the flow of cash for the primary healthcare fund and the emergency and chronic diseases fund will depend on Parliament. Now, we are here in this room and we know Linda Mama depends on Parliament, and Linda Mama has not been paid for 1 year. So I can already foresee. And he also said that what is in his control is the SHIF fund. The others are not in his fund. A lot of providers in this room are level 2 and level 3 facilities. They are going to rely a lot on the primary healthcare fund. How do we cure our dependence on this system? So that is for you, Lillian. I have a question for Millicent. What would it cost for a facility to take the self-care journey right now? Because I know that there is going to be a quality authority. I don't know how many of my colleagues know that, but there will be a quality authority. and the discussions around accreditation will change. It is not going to be as simple as walk to KMPDC or COC or NCK and you pay 80K or 40K and you get a license. No. The future is going to be, are you accredited? Are you certified? How can providers start preparing financially for that certification journey? And finally, to Shafiq, I would like to know whether it is possible for your company to partner with Rupha to do group procurement. Thank you. I don't know if you want to take those ones first, then we can go around the room.
You want to take that first?
Yeah, I can take the first question. Yes, it's possible. And I'll be able to link you with Kathy, who actually administering the platform for further discussions. We have had similar specific designs in Kisumu, $100.
In line, one in the wallet and the dependence on government. And when we first look at the genesis of this, and I'll speak from a financial point of view, is that hospitals are always very happy when they receive the lump sum. And sometimes when you analyze this lump sum, sometimes we forget about the cost that is involved in actually financing, with a bit of humility, the government, because it's the opportunity cost. Today, for your facility to be accredited, you're saying you have to invest first. You have to have the machine. If it's theater, you have to have it. If it's bed capacity that you're looking at, depending on the level, you must have that. If it's actually a scan, you must have all those machines. But they cost money, they don't come cheap. And while I argue that there couldn't be supplier candidate, it's so much one can do. And I've been wondering as a corporate, assuming you had your own medical card as an association, that is, if I'm a patient, I can go to any facility with that card which operates more like insurance, then I get treated, because there is value in the numbers. It's a numbers game. And the other thing, as we look into that, we ask, I operate a corporate. Maybe it will even be cheaper for me to partner with Rufus from our medical care for our teams, and that is operated and managed within Rufus. And we can create a finance group or an investment arm. The monies that is not being utilized can actually be reinvested in a short-term kind of a thing, so that we don't run into crisis. But what's the benefit of doing that is that even smaller facilities get to benefit, because if I get unwell, my origin is Kirinyaga, I don't need to come to Nairobi. If there is a hospital affiliated to Rufus and gives the same quality care, then I can go there and present my card. So to the corporates, it will even be cheaper. And guess what? It will really disrupt the industry and avoid the reliance on the government funds. Thank you.
Thank you very much for the question. I just want to say that there are different packages that one could get for quality, or the journey for quality. One could even start with a self-assessment journey, which is quite affordable. And I don't want to give the actual figure, but I can say this for self-assessment using the platforms. You can get even, that to be honest, is like even $50. But when we talk of the actual assessment where people are coming to your facility, it ranges, you can actually get from 285, depending on the size of the facility, is it a level 1, level 2, level 3, level 4, to even 650. Notwithstanding, the partnership and the collaboration that we've been discussing with Rupha is such that you get a discount and you get a lot of economies of scale. So it depends on the mechanism that one chooses. If you look at other mechanisms like Joint Commission International, they charge millions for one to even just get one accreditation. or one certification. And what is interesting is it's not a stepwise approach, it's a pass or fail. You can call them, they come to your facility. If you fail, you don't get anything. There is no recognition. That money has just gone like that. And that's why we see the likes of hospitals like Adaka now coming to us, that instead of going the way of JCI, can we walk this journey of quality? Because by the time a facility is at CPI level 5, that's equivalent to a JCI accreditation. And if you call JCI, they will pass. Thank you.
Your question was whether Universal Corporation would be ready to do group procurement. This is something that is very positive, and I believe that we can, because there is economies in scale, and together we can work. So yes.
Thank you. Anyone else with a question? Yes.
Sorry. My question goes to the Universal CEO. It has been noted that doctors locally are not prone to prescribing locally manufactured drugs, or even chemists do not like stocking them because of low profit margins. It's not as if the drugs will not be effective, but they are more interested in higher markups. What steps are you taking to create awareness around that, and in partnering with a body like Rupha, how do you think we can make headway around that issue?
Let's take a couple, and then we can tackle them. Anyone else?
Yeah, mine goes to Dr. Wasuna. We partnered with your organization on various areas. First, we started, I don't know whether you're still together, farm access. They ran a program that was, I think, financed by what do you call it, MTBA. And that program was financing diabetic and hypertensive patients. All of a sudden, about 2 or so years ago, it was discontinued. Okay, why it was discontinued, we don't know, but I can assure you it benefited a lot of people. And many of our previous patients have been inquiring whether it is going to be reintroduced, but okay, we have no answer to that. Okay, recently we have also been partnering with Medical Credit Finance, and you can see they're here. So we were just wondering, is there a possibility that maybe you can reintroduce such a program? My question.
Yeah, good afternoon. My name is Evans from Busia County, West Side. I wanted to ask Millicent, the Safe Care pioneer, a question. Now, these payments, now that there's an economies of scale in Rupha, can they be staggered so that people can use, so that we achieve something? Because I think many big institutions incorporate quality, who is accrediting you, who is supporting your quality structures and all that. And I think it's an opportunity that you can help us even break down the costs. To the, I don't know, the finance titles, and we didn't have titles, for example, how else can we access funding to expand our services? Because funding, nobody's willing to fund you, you have salaries to pay. You know, it needs like a different mindset in terms of funding healthcare. That is what I would think. Thank you.
My name is Kefa. I wanted to ask Millicent. A few years ago, just before the COVID struck us, we had a relationship with Safecare. In fact, I still think we hung one of your certificates. I think it's level 2 or 3, I'm not so sure, but I think it's there. Then all of a sudden, it stopped, and we've never had proper explanation. But the engagement we had with you for at least 3 to 4 years was very, very good. Actually, one of your staff or 2 of your staff members used to be in our facility almost 3 times or 4 times a week. And that engagement was very good to us. So I would wish to ask, maybe privately or openly, what can we do to continue that engagement? Then the next question goes to Dream Credit. As you rightly put it, we were like us, we live in a very small town called Maimayu, and the economy of that town is very, very, very low. Actually dependent on sand and stones for building. And when the cost of doing things went down, like the levels of inflation went up, everything collapsed. So our dependence on the government, especially NHIF, was almost 95%. So to disengage because of the problems we are facing has become quite a problem. And now the credit companies, like the other gentleman has mentioned, like, for example, you're still asking for land title deeds. I remember we've had to fill forms over and over with KMET, then eventually it breaks because we don't have the title deeds they're asking for. So I just want to build on what my colleague has said. Can you develop new ways of funding us? Because even when NHIF was still paying capitation in time, or even not too much in time, but they were paying, that lump sum used to help us to move forward and do many things in our facilities. But now when they broke down, that is why there's this hue and cry all over the place. So we're still asking if there is a better way of funding healthcare, especially for low cadre hospitals.
Let me get one more from the ladies, if there is any lady with a question.
I have one though.
Oh, yes.
Hello. My question goes again to Dream Credit. In terms of financing, banks, SACCOs, and everything ask for title deeds and what? Logbooks. Tell me the cost of an X-ray machine. Tell me the cost of an ultrasound machine. The logbook you're taking is less than, because we are buying secondhand from China or wherever, it's 300K. The X-ray machine, what we call C-arm, what we call II machines, are costing upwards of 8 to 10 million. We use logbooks to get access to finance and pieces of land worth $1 million. Yet the facility, which is being rented wherever it is in this country, is having equipment that is upwards of 20 million. How are you people as financiers helping us? Thank you.
Yeah, I think we can take those. Proceed.
Okay, I will address the question on the program on the NTD. The answer is that we have not discontinued. We actually have stages, what we call innovation panel, where we do our innovation. So we would actually first, explore and demonstrate where we are actually, and then hope that will actually inspire others to actually go to sustain. So the program that you are actually talking about, we are actually refining the product to be able to bring up a better value proposition that will touch on the connection, connectivity, and that's between the client, payer, and provider. Now, once that has been defined, we'll come back to you and work with you through your patient support groups. So it's not discontinued. We are just continuing to be able to define the innovation.
How long before you
I think let's have that separate. But with our exploration, you cannot say I'm going to do it in 2 days, because we are also bringing in issues that have been brought up with the Digital Health Act and also the DPA, in terms of the data we collect, how we do everything. So I would say it's soon. Yeah. Let me not say it's Monday or Tuesday. Yeah, and maybe Chair, if you can just allow me to make just a small comment on a question that was brought here seriously. We had a very good talk, I think, by the chair that was great. And there's always a difference between theory and practice. And I know the key issue is actually going to be implementation. Kenya is never, we are never short of policies. And what I'm seeing is that, of course, we are shifting toward a prepayment scheme. And where money is going to be is in the shift, if it's done well. That's where money is going to be. And we should tap into that. Now, what we have to put into account, and these lessons came from the pilot we had in the country. As soon as you and me start paying the 2.75, everybody would rush to hospitals, whichever they are, the ones services. Now, believe me, those services not there to be like. Going by history, they're not there. Now that really puts pressure on the public sector, and that gives you, Rupha, an advantage. In that, in the immediate term, believe me, it takes time to build the system and structure in the public sector. You will have an increased flow of patients. So the question is, can you speak with one voice? Can you strategize? Because that is coming, and that's where you can really tap into the system. It will take time before that is actually done. And if you look at even during the, I don't know whether it was the Sumkati government, where we had two ministries. We had the Ministry of Medical Services, which had, for those of you who can remember, the Hospital Management Services Fund. And money was moving from the treasury going directly to the hospital. And that's level 4 in the bank. That's what we are now calling SHIFT. We also had the Health Sector Services Fund under the Ministry of Public Services. It was there. And that is what we are now calling the Primary Healthcare Fund. We also had an emergency fund. We have just baptized, So the point is, we can't actually have an organization that has existed for about 60 years, and you say you cannot borrow something from them. I think that's just the reality, but you do have a very, very unique opportunity in the immediate term if your systems are ready.
I will still echo what Dr. Ali has said. The alignment will be very, very important. No doubt about it, because one, we cannot wish laws away. We have to abide. But as we abide, we still have to look at our own operations and keep on asking, how can we extract value? And there's a question, the gentleman from Maimahio, regarding of collapse out of the issue of delayed payments. And we need also to start asking ourselves, when we get this money, is the high time we ask ourselves, how do we invest also as near money kind of an investment. In such a way, should there be these delays, either this money is earning that is making your facility be able to meet its day-to-day operations, or one can still use these funds as a near investment to actually also secure facilities within the finance industry. And that way, that can also be a collateral. I need to mention that at times we always look at land, we always look at motor vehicles, what we can see as the only securities. There is a lot, including debentures. And a very good question that was asked about machines which are valued so much. And I know we've been able to combine securities and include debentures, and we've been able to actually buy equipment for some of the facilities. Because the biggest challenge is accreditation. And again, when you want to expand, you also need to offer services that people can actually benefit and also bring revenue. Because again, we are in the healthcare sector, but we still want to make revenue at the end of the day to meet our day-to-day operations. So it's important to critically look at also asset classes, because that will be a game changer. I know for sure government will pay, and the chairman has assured, but the question is a question of when. Yeah, and between this transition, then we need to look at our facilities and ask ourselves the hard questions. How then, based on this, what do we need to do? How can we look at some of the assets we could be having? Can we have short-term measure in terms of securing a facility maybe with the assets that we have? And yes, we have assets because hospitals have equipment. Hospitals, maybe the hospital owner, and there's an example that has been given 300,000. Those are still assets. But sometimes when we look at assets, we only think of mega assets. But yes, we have assets. Challenge to Rufus is also we can work with also the organization in terms of can we, and I know different facilities are classified differently. We need to ask ourselves to what extent different facilities will make sense in terms of the access to the financing. The worst thing one can do is take money alone, paying interest, and is misappropriated. To me, I always say that's a disrespect to the business, because we're expecting it to pay something that was not put actually to the business. So either overfunding affects you as a business owner, where you get the funds, take a holiday, take family to Dubai, but on the other hand, we're expecting business to pay. It's not fair to the business. Yeah, but if we professionalize our businesses, we are able to extract a lot of value. The other value I need to mention, which is a huge credit. When we have good credit rating with our suppliers, we enjoy very good credit term. And that credit term, we are not paying interest, in essence. So we can still, through the value chain, extract debts where we are not paying for in terms of interest. So it's a question of looking at the business, but I'm open. I will remain behind in case of any question, individual questions, so that we see how can we have intervention in this great health sector. Thank you.
Thank you very much for your question. Maybe just to farm up on what she has said, I always say it's easy to turn a doctor into a businessman than converting a businessman into a doctor. So that's really positive for us as Rupha. We're in the right place. So my brother who asked the questions, can we stagger the payments? Yes, we can. I want to even acknowledge, I have a colleague, Dr. Morina Fula, who's very good in number crunching and doing the financial modeling. We will be able to stagger the payment. It doesn't have to be paid all at once. We can agree and see what is feasible, because we are talking to your leadership. Then the other brother who asked about continuation, we have been demonstrating in the market for all those years, but you can only demonstrate for a while, and we have proven that quality creates efficiency, quality increases even your revenues, you're able to seal all the pletharages. So one of the things that we are doing now, we want to sustain. We want a sustainable model. So as we sustain, we are collaborating with you. And yes, we are willing to continue. And that is the collaboration that we'll be having with Rupha. So then it will enable us to even increase reach and impact, because not many facilities were able to
access them. But now when we talk of reach and impact, we need your network. We need to ensure that we can reach as many as possible. Thank you.
The question that was asked was in terms of what Universal is doing with regards to the pricing. So, as we all aware that Kenya is a low consumer of medicines. Most of our medicines are imported, and the volumes that are manufactured locally denies us the margins that we would require, and hence, to some extent, the price of locally produced medicines is higher than what could be imported. However, as we discussed a bit earlier, that if we have the economies of scale and example, Rupha comes in with us and we have the volumes, then definitely we are ready to work on the pricing so that all members are able to get better margins on their purchases and their sales. So that's something that can be worked on, but that requires numbers. Thank you.
Yeah, I think we've come to the end of this panel session. I would like to move to appreciating the panelists for their time. A round of applause. Thank you. Proceed.
Let's appreciate our panelists again. Good. Okay, thank you so much. Let me have my volunteers again. Oh, this is always the first one. I'll send Daisy where I was a few minutes ago to be gifted. You can see my cape. And I have a wonderful pen. These are some of the things that I enjoyed. So I'll tell you because you're my friend. So let's have this. Mohammed, you can carry this? Yes. Oh, it's okay. Yes, there are some gifts coming up on the other end, and I'll be telling you how you can get them. In the meantime, I want to bring in our chairman just to take us to the next level. Karibu, chairman.
All right, thank you, Vice Chairman. Mahmoud reminds me that it is Ramadan. Ramadan? How are you holding up? Water? Now, I can assure you all the Christians in this room have joined you today and they are in shock because we forced them to go for fasting. But somebody told me intermittent fasting is great for your blood sugar, actually. We will be having lunch in about 15 minutes, but this particular session, KCW? So, what is wrong with this? Okay, so these two vehicles, KCW 311W, KCW 311W, and KDM 098F. Please go and attend to your vehicle. KCW 311W and KDM 098F. So, one of my favorite people in the country right now is Dr. Kanyenje Gakombe. Dr. Gakombe is one of my favorite people because he has such clarity of thought and clarity of ideas that every time you speak to Dr. Gakombe, you can only come out better and wonder how you have been living your life without thinking, you know? So Dr. Gakombe has had a stellar career in medicine and in entrepreneurship. Actually, I would say this, if you are a businessman, investor in healthcare, one of the people that you should just plan to have a lunch with or a breakfast is Dr. Gakombe. Dr. Gakombe currently serves as the chairman of the Kenya Healthcare Federation. I have Dr. Gakombe's profile here, and it starts with years of experience over 25. So very experienced. I'm sure those years of experience are more than the age of some people in the hall. He is the co-founder and chief executive of the Metro Group. This is the Metropolitan Group of Hospitals. A serial entrepreneur. How many of you know Metropolitan Hospital? Let me see. Anybody knows? Isn't it? Yeah. So Metropolitan Hospital in Buruburu, together with Ladnan Hospital in Pangani. That's the Metropolitan Group. He founded Alliance Management Systems 2000, which is a hospital software development company that operates in Kenya, Uganda, and Tanzania. He has been, and he's also an investor in real estate. I was given this profile, Daktari. Just later, allow me to read it. So he co-founded Metro Villas and Prudential Asset Management, and served as a treasurer of Kenya Medical Association, among many other things. I don't know if you guys know that Dr. Gakombe sat on the National Economic and Social Council, that was established by the late President Mwai Kibaki, the President's Economic Council. He sat on that. So I think it's a great honor. I cannot, this is so long. Let me not put stress on myself. Let me welcome Dr. Kanyenje Gakombe to give us some remarks today. Karibu Daktari.
Good afternoon. So I'm the one now left to stand between your lunch, and Brian has clearly said I have about 15 minutes. I had a long presentation, but I think I'll dispense with that and basically share my thoughts about how we respond to the challenges that we are going through at the present time. And I want to start by saying that the reason I accepted this invitation is that I have nothing but respect for the leadership of Rupha. And Brian and I have had many conversations, offline, online, in dark space and in open spaces, to discuss how to take the sector forward and what role each of the various players in the sector can do. And Rupha has occupied the space ably. We are doing various other things, but the whole point is to move the ball. It's to get the ball through the goalposts. And the goalposts are a much better financed, higher quality healthcare environment in which we all play. Many years back, at independence, our people faced some of the challenges we are facing. One of them is that the banking system and the financial system that existed then was a colonial system designed to extract resources from us and give nothing back. Our people responded by creating the world's second strongest circle movement to ensure that they could have access to financial resources. The point I'm making is that we have been innovating as a country since independence, and we should continue to innovate whenever we encounter significant challenges. Among the things we have told SHA and the ministry and anyone who cares to listen is that if the money does not flow, it doesn't matter what architecture we come up with, it doesn't matter what we call things, if resources do not flow from contributors to the poolers like SHA, to the providers, and subsequently to our healthcare workers, to our manufacturers and our distributors, the sector will come to a halt. And that message is a message we'll continue to emphasize and we must all work on. Two, is that there is no future in analog systems. And that has been very, very, very well articulated today. And we need to look beyond the healthcare systems, like what Farm Access and CarePay is offering, and look at how we can exploit the entire digital ecosystem, from digitized titles to digitized payments, to drive the sector forward. And in fact, I was tempted to stand up and respond to a question that was asked about financiers asking for titles and various other things. The reality of the matter is the technology people moved and financiers remained behind. Why? Because right now all of us are paid, well, 90-something% of our payments are digital. NHIF certainly does not pay anyone by check. You have to give an account, and they can only send money to that account that you've given. And so it is with insurance companies, with CarePay, and everybody else who pays. All that financier should be doing is to ask Jubilee to lock the account they pay me through, or they pay you through, and NHIF to lock it until they say otherwise. Then they finance you against the expected cash flows from those organizations. You don't need a title, because financing is about leveraging, using money you'll earn in future, getting money you'll earn in future today. The title is just a security in case you stop earning money and someone has to liquidate an asset. But fundamentally, you're saying, I'm going to earn all this money in future. I need some of that money now, so give it to me. So what I'd like to hear from our financiers, and we've been trying to midwife a marriage between KCB and NHIF, but it's not worked yet. And part of the reason it's not worked yet, and I wish the chairman of SHA was here, is a regular conversation that goes on in the corridors of the Ministry of Health. 40% of claims are fraudulent. There is no financier who is going to give any of us money, A, if we are fraudsters, and B, if 40% of the money we are expecting will never be paid. So one of the things we have to emphasize to government, this pending bills business is something we have to move away from, because it does very, very significant damage to the ability to access money from Gashoki and others who are in that space. Because way back, and I think Wasuna knows that time, government tenders were cash equivalent. You'd get money against, whatever order the government gave you, because you're going to be paid. It's not the case anymore, because one doesn't know when you'll be referred to the tender pending bills committee of one sort or another. And one of the best changes that has taken place in NHIF is this split between claim processing and payment, because then we can leverage our good claims that have been processed to access funding from various financiers who are available to give us the money. So when I see Rupha Soft here, it gives me a lot of satisfaction, because when I started, there was no Rupha Soft. I had to build a system. That's how I ended up in IT. There was no system that was affordable. So I did what Kenyans do. We built one. And other people now like it, so it became a business on its own. There is no future in out-of-pocket. That, I think, was emphasized. And that comes with it a condition. And the reason why you must be extremely supportive of the association. It means that there are people who are aggregating the funds before they come to us. Anybody with deep pockets is powerful, whether it's Warren Buffett or SHA or a bank, because in paying you, they can give you a lot of conditions, including conditions about quality, infrastructure, and the rest of it. So the only way to deal with significant buyer power is to have significant vendor power. And since many of us are cottage industries, when we range ourselves against the insurance companies, which are 40, and the banks, which are about the same number, we are much smaller. So the only way to be strong is to aggregate, to have strength in numbers, and to use that strength to then leverage our capabilities to get what we want. And because there is not going to be out of pocket, the old fee-for-service model is also gone. Instead, we have to negotiate tariffs, and there are efforts to negotiate tariffs led by Chuck, and we are plugging into that process. And we need also to negotiate contracts, because historically we've been contract takers and tariff takers. Now we need to be contract givers and tariff givers, so that we are negotiating economic tariffs that we've come up with, instead of starting the negotiations with what the payer has come up with, because they are more likely to be uneconomical than if we come up with them. And that is the other good change that has happened, that the tariffs will now, NHIF will not be setting the tariffs as it's been doing in the past. But if you don't plug into that system, and we are proactive in presenting our proposals, we will still be reacting to unfair arrangements that somebody else has come up with. We need to be alive to the fact that the industry is consolidating. When you see Equity Afia on billboards and all over the place, that is a sign of an industry that is beginning to move away from the cottage stage to industrial scale. So we've asked to ask ourselves, how shall we reach industrial scale? Is it through strategic networks? Is it through using common systems? Right? And the law has also changed to give us certain advantages. Corporate law. Today you can have a sole proprietorship as an individual, which is limited liability. That wasn't the case before, it was not open. Today you can have limited liability partnerships that allow a group of doctors or a group of organizations or institutions to form a business association without taking unnecessary liability as individuals. And one of the proposals I would wish to give your able chair is the possibility of Rupha starting an LLP, for collecting the money and distributing it to the members, much the same way that you are working on the software, so that the negotiations are now not about an association representing people, but about a business entity signing contracts on behalf of its members and acting on behalf of its members without having to ask, please vote whether you are going to stop, because the stoppage will be by switching off the software. I don't know whether any of you remembers, in the old days when banks were closed, and these are the possibilities we need to look at. It was by sending guards to the individual branches to stand there and with a paper pasted on a bank door saying closed. Chase Bank was not closed that way. They went and got the digital people and they closed the server. There was no need to go and stand at a door saying Chase Bank. Well, the notice was put there, but the bank was closed on Riverside. Yeah? So rather than Rupha doing a poll, it should be possible to say the NHIF scheme or the SHA scheme is now on a cash basis without having to do what you're being forced to do today. I think the HRH changes were covered. The point I'd like to make is that we have an opportunity to train for the world. The world has a shortage of healthcare workers. Yes, we have doctors who are doing what they must do to get jobs, but the world has a shortage of certain cadres of healthcare workers, and we should be seeing that as an opportunity for additional revenue streams into our institutions. I hope some of you are already in training, One Kenyan told me, in fact, you should forget about earning money from giving care and have patients for free, because the students will give you enough money to treat them for without having to pay. There is an opportunity in the new payment model, fixed prices for universal and the rest of pharma. Why? Because the old incentive of price plus markup went away. Instead, we are being offered a fixed sum of money to treat particular conditions. And in that model, everything you use is your cost. So generics become a very attractive proposition in those circumstances. Because if you buy more expensive drugs, you're simply reducing your margin. And I would want to see where pharma is, local manufacturing, now, and we see where we'll be a couple of years as these changes take place. I checked my own data. We are very data-driven. Purchasing from local manufacturing is 2.38%. Because as part of the effort to promote local manufacturing, we started by looking at our data. How much are we buying from local manufacturers? And I'm embarrassed to say that it is 2.38%. India was somewhere up there with 16 or 18%, followed by the UK and I think the US. We have to consider the fact that with the counties becoming, the healthcare facilities in the counties becoming funded directly, they'll become a bigger competitor to us. So we need to look at the competitive landscape, look at the counties both as a collaborator, because they'll be fighting for money when you're fighting for money, fighting for better tariffs when you're fighting for better tariffs, and also as a competitor, to avoid the fate that befell schools when Kibaki declared, with his Nusumukata partner, declared education free. Those of you who remember that schools that were low quality providers closed. So please listen to Millicent, because if people are coming to you because there is nothing better, and then the counties improve the patient experience, then we may find some of our clients opting to go to county facilities. And I'm giving that warning deliberately because I am part of, my latest job is helping Murang'a County to benchmark with Rwanda, not with another county. There is no county we think is good enough as a benchmark, so we are benchmarking with a country. And Brian can tell you that every single healthcare facility in Murang'a is being digitized. Computers are being delivered at midnight. Connectivity is being established. In another week, there will not be a single analog healthcare facility owned by the government of Murang'a County. So if you are not on Rupha Soft, and you don't have something better, you are already behind. Yeah? Because my brother did say government will take time to organize, but some counties will organize fairly quickly, and we need to be on the lookout. So the long and short, ladies and gentlemen, is that in the changes that are coming and have happened, in there are strategic opportunities. And it's extremely important that we continue to explore those opportunities as an industry, whether it's Fireside Chat will do, or, bring experts like Owino. We need to look at the opportunities. And some of us got stuck in that book and do not know any other book in the Bible. We move away from that and we begin to look at opportunities for growth. And there is a big one. All the sagas that were putting their money in HIF, they will still need private cover. Because one of the things we bargained and won was no contribution from the employer. That has very significant meaning to all of us. Because that money will go through somebody else because they'll still need the care. The SHA will not do enough for all of us. All government services are basic. If you expect the government to give you a Lamborghini and you're not an entrepreneur as a service, your thinking is not right. The government will give you a road, it may give you a bicycle, it may give you a cycling lane, but that's as far as it goes. So anybody who wants something better than basic will still have to buy it, and we should be aiming to provide that service. And the biggest challenge in the industry is that we are not adequately organized. The reason people go to MAKL, the reason they go to Minet is because there is no established private provider network that can be contracted through to reach all the members in this room. So we allow other people to organize us, and they keep the lion's share of the cake. Therein lies our great opportunity. To support Gashoki, I will also offer 5 hours, so you can add 5 more people to your list. Those who think they may benefit from an hour spent with me, and I'm willing to be the one to buy the coffee, please add those hours. I'll finish by saying that the journey we have walked is a journey many of you are walking, and it's a journey that can lead to a much bigger, longer destination than where we are. We are beneficiaries of Safe Care. We are beneficiaries of the Medical Credit Fund. We are beneficiaries of debentures. We are beneficiaries of private equity. We are beneficiaries of associations like Rupha. That's why I'm still involved in this space, because there are many things we could never do alone that were only possible through KEPSA, through Kenya Association of Hospitals, through CAF. So, and I think she said it, there is no other way to walk except to walk as a group. Because if you attempt to walk alone, the carnivores will have you for breakfast. We are in the Serengeti. If you do not stay in the herd, you are likely to become somebody's breakfast. And that's not a very good outcome. Thank you.